Topic for discussion now is swellings of the jaw. And as we all know, this jaw swellings can be of predominantly two types. It could be either of a soft tissue swelling or a hard tissue swelling. Usually the swellings could be either because hypertrophy of the cell, or it could be because of a hyperplasia, that is a growth of the cell or just increase in the size of the cell, or it could be because of any fluid collection or fluid accumulation, or it could be because of abnormal proliferations of the cells that are present there, that is nothing but your tumefactive growths. So there are various reasons, or it could be because of edema, either because of any trauma. There could be swelling on the region because of an edema or collection of fluid there, inflammatory because of inflammatory reaction happening there. So we have different types of swellings. You can have a small abscess itself because of infectious in origin. So these all come under various swelling of the jaw. So today we will be discussing in brief about different types of swellings of the jaw. We actually will discuss about the soft tissue swellings and the hard tissue swellings, and also we will be discussing about two important jaw swellings, that is dentiginous cyst and also the ameloblastoma, which is a benign tumor. So first, before going into this tumors of or the swellings of the jaw, to be precise, we have various swellings, as I told you, the soft tissue swellings and hard tissue swellings. So to grossly classify them, we have swellings from the mucoperiosteum, that is apellis-like structure. We have various types of swellings, especially in the soft tissue. We have fibrous growth or fibrous swelling. We have a granulomatous growths, we have myeloid growths, we have sarcomatous and carcinomatous. Coming to this fibrous growths or fibrous type of swellings within the oral cavity, the most important one or the one that we commonly encounter are inflammatory fibromas or traumatic fibroma. Fibroma is actually a benign proliferation of the fibrous connective tissue or fibrous cells, that is fibroblast to be precise. So this is a fibroma, and the etiological factor for it could be either an irritation or trauma. Trauma, constantly biting of your buccal mucosa or tongue, or constant injury to it through a sharp cusp can lead to traumatic fibroma. Or in the gingiva, what happens, there will be much amount of calicles continuously irritating your circular side of your gingival tissue, resulting in your irritational fibroma. And this fibroma, initial stages, we also have other type of tissues like pyogenic granuloma. Normally what happens is, in this fibrous tissue, it is again a small ovoid or round in shape, and it is firm in consistency because of the fibrous content present within it, and usually most of them are painless unless it is secondarily infected or it has an ulcer over it, traumatic ulcer kind of stuff. They are painless. It is a benign in growth, slow growing. It grows for some period of time. So the treatment for it could be a normal surgical excision, okay, in case of this fibrous growths. Now we have something called as granulomatous growths. In this granulomatous growth or granulomatous swelling, the a small thing is pyogenic granuloma we have because of again irritational factors there present, also because of a fluctuation in the hormones, most commonly seen in puberty and in pregnancy time. And in pregnancy, if it occurs, it is called as pregnancy tumor, okay. These are granulomatous one. And we have other diseases which are actually causing granulomatous kind of swellings within the oral cavity. We have hereditary angioedema. We again have sarcoidosis leading to granulomatous, it is a granulomatous infectious swelling of your gums, okay. We have these are come under granulomatous kind of growths or swellings. We have something called as myeloid, myeloid growth. Myeloid growth of gingiva, usually seen in case of leukemias, some kind of leukemias. We actually see a boggy kind of gingiva, where gingiva is enlarged, swollen because of infiltration of this myeloid cells present, myeloid cells within these gingiva, okay. And we have sarcomatous condition, and also we have carcinomatous growths also present, usually seen in case of buccal mucosa, on the tongue. Ulceroproliferative growths are present, most commonly seen on the buccal mucosa, on the tongue or on the lip. Also we can see this carcinomatous growths. Usually patients will give us a history of pan chewing or tobacco chewing or smoking history. Usually pan or tobacco chewing is the most common complaint. Some kind of viruses, oncogenic viruses, are also associated with this carcinomatous conditions, especially HPV, and we also have HTLV. These viruses are known to be oncogenic viruses, and these carcinomatous growths are usually initially they will be proliferative in occurrence, and later they proliferate and become ulcerative, and that complex can be called as ulceroproliferative growths. And whenever we see this ulceroproliferative growths, for example on the tongue, it is usually an averted one. Squamous cell carcinomas could be an averted ulceroproliferative lesions. Usually a characteristic induration of the mucosa surrounding it can be present, and it is firm to hard in consistency. Sometimes lymph nodes can, many a times lymph nodes can be involved. And lymph nodes are usually they are stony hard in consistency, fixed to underlying structures, usually non-pain. I mean, they do not have any pain, painless. And they are not mobile. Okay, these are about various carcinomatous growths or carcinomatous swellings that we can see within the oral cavity, and these comprises of the soft tissue growths. And we have something called as odentomes, usually from the tooth gem, and these odentomes are again of various types. We have epithelial odentomes, we have connective tissue odentomes, and composite odentomes. Coming to these epithelial odentomes, which includes radicular cyst. Radicular cyst again is a traumatic radicular cyst or periapical cyst. This is because of any trauma or any infection within the tooth. That is like your dental caries. Okay, when the pulp is involved, what happens is there will be formation of periapical granuloma in reaction to the infection present there. And this periapical granuloma, the center can undergo into cystic degeneration, resulting in a radicular cyst. In radicular cyst, usually a swelling can be present within the bone. Okay, and we can see in case of radicular cyst, we can see vestibular obliteration, vestibular tenderness can be present sometimes, nice crepitus can be present, and on palpation it is usually soft in consistency and cystic. We can actually see fluctuations in case of this radicular cyst, and treatment for it would be endodontic treatment of the tooth and enucleation of the cyst, or episectomy has to be done in case of your radicular cyst. And if it is a larger cyst, we do enucleation or marsupialization in case of your radicular cyst. Then we have something called as dentigerous cyst. Dentigerous cyst is something which is usually associated with an impacted tooth or a submerged tooth, or a supernumerary tooth, or it can involve a normally erupted tooth, but most commonly the above three are involved. In this, what happens is the follicle, that is nothing but your enamel or the tooth surface and your reduced enamel epithelium, the distance between it is increased, the follicular space is increased. The normal follicular space can be 3 to 4 mm, and in case of this dentigerous cyst, it usually exceeds more than 6 mm. That is, in detail we'll talk about dentigerous cyst. And we have something called as ameloblastoma. It is again a benign tumor of the jaws. Also an example of epithelial odentum, that also we'll discuss in detail. And we have connective tissue odentomes like cementomas. Cementomas is nothing but abnormal proliferation of the cementum, where we can actually see a bulk, bulk of the it is a benign tumor of the cemental cells, where we can see bulk attached to the root surface. These are nothing but cementomas. We have fibrous odentomes and sarcomatous odentomes. Coming to composite odentomes, we have radicular odentum, complex composite odentum, and compound follicular odentomes. Next, we have something called as inflammatory swellings. The most common inflammatory swelling is a dentoalveolar abscess. Usually, it is a sequel of a dental caries, which will be involving the pulp, and later it causes a periapical periodontitis, where your periodontal ligament space is widened, and the lamina dura, which is actually containing the tooth, can be disrupted. And we can also see a periapical radiolucency result, which is actually caused because of an inflammatory reaction, because of the abscess formation. And we actually, in this dentoalveolar abscess, what happens is the periapical infection or pus which is present there can seep into the adjacent spaces, tissue spaces, that can lead into cellulitis also, which is again a sequel of your dentoalveolar abscess. In case of dentoalveolar abscess, the tooth is usually tender, and we can see vestibular obliteration with vestibular tenderness is usually present. We can also sometimes see an extraoral or intraoral sinus opening with the pus discharge is usually evident in case of your dentoalveolar abscess. Again, treatment for this is patient is put on antibiotics, and later a root canal therapy or endodontic therapy has to be done to treat the cases of dentoalveolar abscess. Next, we have osteomyelitis. Osteomyelitis is again a sequel of this chronic dentoalveolar abscess. Here we see a periosteal reaction leading to changes within the bony structure, the trabecular pattern, and we can see involucrum and sequestral formation in case of this osteomyelitis. Actinomycosis, again usually cervicofacial actinomycosis is a variant where which can as a swelling of these jaws. In this actinomycosis, what happens is we can see sulfur granules, which is a characteristic feature of this actinomycosis. And we have something called as osseous tumors. These osseous tumors can be either benign tumor or a malignant tumor. Benign tumors can be again of various type like ameloblastoma, etc. And this malignant tumors of the jaw can be like benign tumors can be your ameloblastoma. We can have odontogenic myxoma, etc. Whereas malignant tumors can be metastatic tumors of the jaw. We actually have squamous cell carcinoma of the alveolar bone, soft tissue tumors attacking the alveolar bone. These are again osseous tumors. And cyst is nothing but collection of fluid within a contained space, and there are many number of odontogenic cysts. We have cyst within the bone, and these cysts can be either odontogenic cyst or non-odontogenic cyst. Cysts of the jaws are again divided into epithelial and non-epithelial in origin. Epithelial one are again divided into developmental or inflammatory in origin. Developmental ones again odontogenic and non-odontogenic. In odontogenic cysts we have dentigerous cyst, we have odontogenic keratocyst, we have gingival cyst of newborn, we have gingival cyst of the adults, we have lateral periodontal cyst, we have calcifying epithelial odontogenic cyst. In non-odontogenic cyst we have median alveolar cyst, we have median palatal cyst, median mandibular cyst is present, we have nasopalatine cyst and nasolabial cyst. So these are various cysts of the jaws that are present based upon the Shear's classification. Now coming to dentigerous cyst is again, as I said, is one of the most common cysts that has been encountered in the oral cavity. It is the one which encloses the crown of an unerupted tooth by expansion of its follicle and is attached to the neck. Remember, this follicle is always attached to the CEJ junction, that is your cinvento-enamel junction. However, the widening of your follicular space, usually the attachment at the CEJ is usually maintained in case of your dentigerous cyst. And coming to etiopathogenesis, it can be either intrafollicular, extrafollicular, or adaptation of the teeth or inflammation in origin. Now coming to clinical features, usually it has been associated with unerupted teeth or embedded teeth or impacted teeth. Normally we can also see in case of supernumerary teeth or complex compound odontums associated dentigerous cyst. The most commonly dentigerous cyst is usually seen in case of mandibular third molars. It rarely involves any unerupted deciduous teeth, and usually seen in case of second to third decade of life, most commonly seen in males, and mostly these are usually solitary in nature. If we see bilateral or multiple cysts, they are seen in cleidocranial dysplasia and Maratox-Lamy syndrome. And small dentigerous cysts are usually asymptomatic. They are accidental findings. Only in case where we actually take an orthopantomograph for any other dental investigation, accidentally we might actually, as an incidental finding, we may encounter small dentigerous cysts. So usually they are asymptomatic. But these dentigerous cysts has a propensity for painless expansion of the bone, and they can lead to facial asymmetry. They are very much expansive, very much aggressive, and then can lead to massive destruction of the bone and also very huge swellings. Usually teeth here are often displaced, and sometimes the mandibular canal or can be displaced, and also it can also lead to encroachment into maxillary sinus if it is affecting any of the teeth in the maxilla. And we have various variants of these dentigerous cyst. We have central variant, we have a lateral variant or circumferential variant. Central variant is nothing but a dentigerous cyst is present around your crown of the tooth. Okay, it is a central variant. And lateral variant, dentigerous cyst is present along the lateral side of your tooth. Okay, from the follicular space is enlarged along the lateral side. And in case of circumferential one, here we can see the dentigerous cyst enveloping the complete tooth structure, also called as envelope variety of dentigerous cyst. Okay, and we have various investigations like aspiration. On aspiration of dentigerous cyst, we actually get a straw, straw-colored serosanguinous, straw-colored fluid is usually obtained in case of dentigerous cyst. In this OPG, radiographs, as I said, orthopantomograph is usually very much useful. And we can also go ahead with occlusal radiograph to see any bilateral cortical plate expansion, and biopsy we can do for incisional biopsy, or complete excision of the cyst can be sent for excision for histopathological investigation to determine if there are any malignant changes that have been occurring in this dentigerous cyst. Normally this dentigerous cyst clinically what happens is when we actually see clinically, we can see obliteration of the vestibule in that region if it has enough amount of swelling, and then when we palpate, we can actually have that cystic consistency, and if it has involved any of the cortical plates, we can actually observe crepitus that is usually present in case of your dentigerous cyst. And coming to management, enucleation can be done and has a very excellent prognosis in case of dentigerous cyst. Usually we do not see much amount of recurrence in these cases. Coming to the complications, this lining of dentigerous cyst actually has a neoplastic transformation ability. It can transform into an ameloblastoma, it can transform into a squamous cell carcinoma, or it can transform into an intraosseous mucoepidermoid carcinomas or carcinoma of any mucous cells. In this, what happens is, that's the reason when you're doing an incisional biopsy or excisional biopsy, the lining epithelium has to be examined to rule out if it has any neoplastic transformation. Okay, so dentigerous cyst is one of the most important cysts that is usually encountered in case of your routine dental practices. Then we have something called as ameloblastoma. Ameloblastoma is again a benign tumor, also called as adamantinoma, Eve's disease, or multilocular cystic disease. Initially, it was thought to be a hard tissue, tissue that is making proliferation of hard tissue, okay, because amelo is nothing but is your enamel, right? It is a hard in consistency. But in due course of time, it was understood that it does not only produce hard tumors, hence the name was later changed to ameloblastoma. According to Robinson, this ameloblastoma has a definition where it is usually unicentric, it is non-functional. Remember, ameloblastoma, it is nothing but proliferation of ameloblasts, right? But these are non-functional because they do not secrete any enamel-like material. Hence, they are non-functional. It is intermittent in growth. It is slow growing one. Okay. It is anatomically benign. It is a benign tumor. Anatomically, it is a benign tumor, but it is a clinically persistent lesion. It persists for a longer period of time. Hence, it is usually unicentric, non-functional, intermittent in growth, anatomically benign and clinically persistent lesion. Normally, it is a fluid-filled or jelly-filled type of lesion. The sites are usually, most commonly it can be seen in the mandible, that is the jawbone. We can also see them in stalk of pituitary, that is suprasellar tumor, in tibia, in soft tissue, especially in the gingiva, also called as peripheral ameloblastoma. It usually spreads by local invasion. We do not usually see any metastasis in case of this ameloblastoma. However, we have a variant called as malignant ameloblastoma. This might show metastasis because it actually appears, it functions as a malignant tumor. Coming to pathology, we see a columnar layer cells in the outer layer, whereas her ameloblast or star cells can be seen in the center, which has epithelial strands, and islands can also be seen. The tall columnar ameloblast-like cells are present, where central degeneration which shows up cystic spaces. And ameloblastoma is usually classified as unicystic ameloblastoma, peripheral ameloblastoma. We have classic solid multicystic ameloblastoma and desmoplastic ameloblastoma, which also includes a hybrid lesions. And histopathologically, we again have various types of ameloblastomas like follicular ameloblastoma, desmoplastic ameloblastoma. We have granular ameloblastoma and cystic ameloblastoma. Among these, granular ameloblastoma is known to be more aggressive type, whereas your desmoplastic one is known to have more amount of malignant potential. Okay, and clinically for us the two types are more important. One is cystic variant and one is solid variant. In cystic variant, we can, on aspiration, we can obtain fluid can be obtained, whereas in solid variant we cannot get any fluid on aspiration. Coming to clinical features, usually it is seen in young adults and childhood age group, and males are most commonly involved. In the jawbones, usually the posterior mandible and the ramus of the mandible is usually most commonly involved. It is a slow growing one, usually painless, but it is very expansile. It can grow into a size of this much. Okay, it is an expansile lesion. There can be cystic degeneration. That's why I told you the other variant is cystic variant, right? There can be cystic degeneration. If there is a cystic degeneration, you have a clinical feature of soft eggshell crackling can be encountered in those cases of cystic ameloblastomas. Coming to investigations, we can do an aspiration and also we can do a biopsy, and then on an X-ray, which will actually help us. We can, if it is a multicystic one, we can see multi or locular. If it is unicystic, unilocular, osteolytic lesion can be seen here, that is radiolucent lesion, and it also has, in case of multilocular one, we actually have small locules can be present. Usually it is called as honeycomb appearance, and in further period of time the locules they get increased in size, resulting in soap bubble appearance. These are radiographic features. And we have something called as variants, again clinical variants like recurrent ameloblastoma and malignant ameloblastoma. As we have discussed, malignant ameloblastoma has propensity for malignancy. Recurrent ameloblastoma is something where we have multiple recurrences in the same area. Once it has been operated, in another area we get the ameloblastoma. This is nothing but recurrent ameloblastoma. So how do we manage? Enucleation, curettage and resection of the tumor are treatment of choice. Radiotherapy is very ineffective. It does not respond to radiotherapy. Hemimandibulectomy may be required if the lesion is extending up to the symphysis, or if it's crossing the midline region. We go for hemimandibulectomy. In those cases, whenever hemimandibulectomy is done, we go with prosthesis, celastic rods or block bone graft. So this is about ameloblastoma. So this is about various swellings, both soft tissue swellings and hard tissue swellings of the jaw. Hope you have understood about various jaw swellings, and in detail we have also seen about ameloblastoma and dentigerous cyst. Thank you.